The infection, that's silently killing coronavirus patients. We are not detecting the deadly pneumonia the virus causes early enough, and that we could be doing more to keep patients off ventilators and alive. Even patients without respiratory complaints had COVID pneumonia. In patients on whom doctors did CT scans because they were injured in falls, they coincidentally found COVID pneumonia. And here is what really surprised us: these patients did not report any sensation of breathing problems, even though their chest X-rays showed diffuse pneumonia and their oxygen was below normal. COVID pneumonia initially causes a form of oxygen deprivation doctors call silent hypoxia silent because of its insidious, hard-to-detect nature. But when COVID pneumonia first strikes, patients don't feel short of breath, even as their oxygen levels fall. Normal oxygen saturation for most persons at sea level is 94% to 100%. COVID pneumonia patients I saw had oxygen saturations as low as 50%. In emergency departments, doctors insert breathing tubes in critically ill patients for a variety of reasons. However, most patients requiring emergency intubation are in shock, have altered mental status, or are grunting to breathe. Patients requiring intubation because of acute hypoxia are often unconscious or using every muscle they can to take a breath. A vast majority of COVID pneumonia patients had remarkably low oxygen saturations at triage, seemingly incompatible with life, but they were using their cell phones as doctors put them on monitors. As the inflammation from COVID pneumonia starts, it causes the air sacs to collapse, and oxygen levels fall. Patients compensate for the low oxygen in their blood by breathing faster and deeper, and this happens without their realizing it. This silent hypoxia, and the patient's physiological response to it, causes even more inflammation and more air sacs to collapse, and the pneumonia worsens until oxygen levels plummet. 20% of COVID pneumonia patients then go on to a second and deadlier phase of lung injury. By the time patients have noticeable trouble breathing and present to the hospital with dangerously low oxygen levels, many will ultimately require a ventilator. Silent hypoxia progressing rapidly to respiratory failure explains cases of COVID-19, patients dying suddenly after not feeling short of breath. And because so many patients are not going to the hospital until their pneumonia is already well advanced, many wind up on ventilators, causing shortages of the machines. There is a way we could identify more patients who have COVID pneumonia sooner and treat them more effectively, and it would not require waiting for a coronavirus test at a hospital or doctor's office. Widespread pulse oximetry screening for COVID pneumonia, whether people check themselves on home devices or go to clinics or doctors' offices, could provide an early warning system for the kinds of breathing problems associated with COVID pneumonia. There also may be some patients who have unrecognized chronic lung problems and have borderline or slightly low oxygen saturations unrelated to COVID-19. All patients who have tested positive for the coronavirus should have pulse oximetry monitoring for 2 weeks, the period during which COVID pneumonia typically develops. Patient positioning maneuvers, having patients lie on their stomach and sides, open up the lower and posterior lungs most affected in COVID pneumonia. Oxygenation and positioning helped patients breathe easier and seemed to prevent progression of the disease in many cases. In a preliminary study by Dr. Caputo, this strategy helped keep 3 out of 4 patients with advanced COVID pneumonia from needing a ventilator in the first 24 hours.